click on the speaker there, and then slide up. Audio in is on. Okay, so you guys should be able to hear me now, and I apologize for that. I'm streaming in Singapore for the first time, and so it's just taking me a little while to get the technology all set up. So this is a kitty that has a corneal ulceration and glaucoma, and has a non-visual eye, and so we're doing an enucleation. Just retract on that for me, please. And this cat's eye is very painful, and so that's why we're doing the enucleation. Now, the confounding factor here is that this kitty also has metastatic lung cancer, and it has one large pulmonary nodule, and then it has multiple metastatic lesions. And so the owners understand that the life-limiting factor in this cat is the pulmonary carcinoma, but the quality of life right now is most affected by this corneal ulceration. And so, understanding that survival may only be several months, they've decided to go ahead and do the enucleation anyway. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So again, I am streaming from Beecroft Veterinary Specialist Center in Singapore. I'm doing a locum here for about 3 weeks. I just started yesterday, and it's been really, really fun working with a new team with outstanding equipment and great procedures and very knowledgeable staff and stuff, so that makes it really fun and easy for me to come in as a specialist and to do a good job. Apologize for the issues with the audio, because this is the first time I've live streamed outside of my practice, and so there was a little hiccup with the technology, and to be honest with you, I forgot to connect the microphone. So when I do an enucleation, the first thing, that's okay, you can leave that there. First thing that I do when I do an enucleation is I suture the eyelid shut, and it just find it easier to make sure that we're removing all the secretory tissue from the orbit, because if you leave any secretory tissue in there, you're going to have a foreign body reaction and draining tracts develop and that kind of thing. Can you tell me what the electric cautery is set on, 20 and 20? Can I have that up to 30 and 30, please? And the extent of my knowledge when it comes to ophthalmology, is enucleations and eyelid masses. Anything that's deeper than the eyelids, I don't know anything about. And I'm very happy to admit that. So we're just going to make now an incision through the skin. Around the eyelid. And I might have you retract on that skin for me a little bit. I apologize. Can you turn this back down to 20 and 20? You have very powerful cautery in it. Okay. Thank you very much. So then I'm just incising around that eyelid, making sure that I'm getting the nasolacrimal ducts and all of that secretory mucosa, the third eyelid, everything. And when you first start doing every enucleation, you always feel like you're a little bit lost on establishing your initial dissection plane. And despite having done a bunch of these, I always find that it's a little bit tricky to start with. Do you have some tiny Gelpi retractors? Little. So there's a question about why I'm locuming in Singapore. When I left Southpaws in Melbourne, I wasn't sure what I was going to do going forward. I had a friend who's an internal medicine specialist here in this practice in Singapore, and I just asked if they needed a locum. Now I'm working permanently with Green Cross and Melbourne Vet Specialist Centre in Melbourne, but I had committed to doing this locum, and so that's why I'm here, but I do intend probably to keep doing it, as in to come back and do more, because it is such a great team and great equipment and a beautiful city. So it is something that I could see continuing to do intermittently as needed. It's interesting to know, I've been having some discussions with the business managers about challenges that they have running a referral practice in Singapore, and it's the same issues that we have in Australia, so it's pretty universal, the challenges that we have with staff and encouraging referrals by primary care vets, and communications and all those things are pretty universal. So what I need to do is go basically all the way back to the orbit to make sure that I'm getting all of that secretory tissue. Can I get cautery turned down even a bit further, down to about 10 and 10? So this cat has glaucoma and a very severe corneal ulcer. Thank you. And it's very painful in its eye, and it's also non-visual. Jesse, I've sutured the eyelid shut, and then I've just made it a skin incision around the sutured eyelid. And then basically I'm going to go all the way down to the orbit. So I'm at the orbit dorsally here. Yeah. Now the one difference when you're doing a cat enucleation compared to a dog enucleation is that if you tether the optic nerve in a cat, you can create blindness in the contralateral eye, yep. Which is something to be aware of. And so we just have to be careful with how much tension I put on that optic nerve. Do we have a freer elevator?
Freer prayer of the elevator should be here.
Yeah, thank you.
No problem.
So I'm just using the freer now to dissect the soft tissues from the inside of the orbit. And just so you know, Jesse, I am live streaming.
Yeah.
But you guys are encouraged to ask questions.
No problem. Thank you.
Heavy you retract on that for me, please? So I'm down to the orbit here as well eventually. So you can just feel, if you guys want to palpate and feel that orbital bone, ventrally and then dorsally as well. And there'll be some connective tissue medially and laterally that you have to go through. And then caudally we'll have that zygomatic ligament right there that we need to, I prefer to avoid damaging it. It's not critical, but let's just see what we've got here. All right, so that's released now and freer.
Yep.
So then I'm just releasing that soft tissue all the way around. And there is going to be a blood vessel that always bleeds associated with the optic nerve. And basically, there's no way to get it to stop bleeding except direct pressure. Let me just tuck that in there.
Do you ligate it usually?
You can try, but you can try to ligate that vessel, but I have been unsuccessful. So usually I just do direct pressure for 5 minutes. And that means that we've got 5 minutes to wait, so you, Chessie, will have to come up with a joke. So you're under pressure, but you've got a few minutes to come up with one.
I'll try. Or anyone else in the room that has a joke?
And it can't be inappropriate. Those you'll have to save for when we're not on the air. So we're just now transecting the periocular muscles. The zygomatic salivary gland right there. And here's the point at which I have to be careful not to tether on the optic nerve too much. So now I can just reach in with scissors .
You're sending this out for visual pathology. The owner has contacted me.
Yeah, and so now we just pack this off for about 5 minutes. So that's the eye that we've removed there. Those are the extraocular muscles that have been transected. Periocular fat. Can I get a 5-minute count, please? There's a comment or a question, a couple of different ones. One, can you remove the intraocular liquids in order to make it easier to manipulate the eye? I suppose that's something you could do, although it's nothing that I've ever done before. Part of the reason for that might be that I, as a cancer surgeon, am often doing this for neoplasia, and so I'm reluctant to release those fluids into the surgical incision. I don't know if that makes any difference or not. There's another question about exoneration or enucleation. This technically would be an exoneration because I'm taking all the orbital contents out. So the next level would be like an orbitectomy. If I had cancer that was highly malignant, you can actually remove that whole orbit by cutting through the bone of the skull and taking that out at the same time. The question about adrenaline instead of direct pressure. I suppose adrenaline is something that you could use. I've never used it. I've always just packed it off and for 5 minutes, and that's always taken care of it.
Question. With regards to one of the complications keeping the tear glands intact. So does closing during the palpebral way avoid that? That's the main reason that we do that, right?
Yeah, so we're suturing the eyelids together, and then cutting around that whole thing. We're staying out of the conjunctiva the whole time, which means that we're taking out the tear ducts.
Okay. Yeah. That's why you mentioned to us to follow the orbital rib to make sure that we get good enough margin.
Yeah,
okay.
yeah.
Your cut is really clean because when I do it's so bloody.
Yeah,
I think I'm going to use the cautery next time as well.
Yeah, I use cautery for everything. Yeah. It's like, so I've scrubbed with a lot of human surgeons, and they have it up on 60 and 60 or whatever the whole time, and it's just sparking and smoking and whatever. I'm not quite that aggressive, but it just shows that you do have a bit more margin for using electrocautery for your dissection. How much? 2.5 more minutes. It's the longest 5 minutes of a surgeon's life.
I got a joke.
Okay, we've got a joke. Okay.
So
I'll bring my microphone closer.
What do you call a deer with no eyes?
What do you call a deer with no eyes?
Yeah. Since we're on eye surgery today.
Yeah.
Do you guys know? What do you call a deer with no eye?
No idea.
Sorry, a bit late.
What do you call a deer with no eyes and no legs?
No idea. No, still no idea.
Still no idea.
Oh, come on.
And there's another level that I will not tell on Livestream.
Okay. Answer. So just now we did transact the zygomatic ligament.
No, it's still there.
Oh, so this is the.
Yeah, it goes from, there's a little point in the zygomatic arch that extends up to the frontal bone.
Okay. So as long as we go along the rim, we will avoid that, right?
Yeah, yeah.
Okay.
So it's just the zygomatic ligament's just right there. Feel that? It's very firm. So it's actually an incomplete orbit.
I see.
So the margin, the orbit comes down to here, to the frontal bone, zygomatic bone, and then the zygomatic ligament makes up the lateral extent or the lateral margin of the orbit.
I see. Okay. Yeah, sometimes that was a fibrous thing that when I cut, I feel it.
Sorry that's blurry, guys. See if I can get something to...
50 seconds left.
Not sure why that's blurry.
Do you want to try adjusting?
Once, it should be on autofocus. Once I remove this, I'm still bleeding. Let me just see if I can see what's bleeding in there. Where's the thumb fork? Hemostat.
Alright, thank you, Zizi.
So I found the bleeders and I've clamped them off. Do you have hemoclips here? Large hemoclips? Let's see what size you've got. Yeah, let me. Hemoclips. The yeah, titanium clips.
Maybe exotics, Zillion.
Would you put any like gel foam on, you know, the bovine?
Yeah, you can do that. Yeah, that can be helpful. So that's the infraorbital nerve right there going into the infraorbital foramen. See that? Right there.
Ah, this one, okay, yeah.
Yeah, so it's going in here and then coming out right there. I don't know if you guys can see that. Probably the angle isn't allowing you to see that, but there's a large nerve sitting right there.
Yep.
So there's another question about putting in gel foam or something like that, and it can be helpful, although when you've got basically arterial bleeding, that probably isn't going to do the trick. Yeah, great, thank you. So there's a question, do we routinely do peribulbar block for enucleation? And the answer to that is yes, we do. And we've done that in this case. We've got a really hotshot anesthetic team here that does all this stuff. And we are not putting in a prosthesis in here. Yeah. I don't know if I've ever done an intraocular prosthesis or an intraorbital prosthesis for. It's just for cosmesis, so it doesn't sink in so far.
Sorry, Doc, we only have one size of the hemoclip, if that's okay?
Might be a bit small, so we'll just, yeah, all good.
So we don't need this?
Nope.
Okay.
Thank you very much.
No worries, Doc.
I don't know if I can get a suture somehow around there.
Stop bleeding.
Yeah, so I'll just pack it off for another minute. Can we get some 3O PDS, please?
Cupping, Doc?
Beg your pardon?
Cupping or?
Taper if you've got it. If you don't, then cutting's fine.
Do you also usually flush into the, like, the orbital? No.
Nah. Oh, start it again. Do we have gel foam?
Yes.
Can I get some gel foam, please? So they've discontinued gel foam in Australia. Have they discontinued it here as well? Yeah. So we're looking at that purified bovine collagen.
This is a bovine.
No, that's just, yeah, that's just gel foam. So I've talked to, what is her name?
Melanie?
Melanie,
Yeah.
about
The bovine.
the bovine.
Why did they discontinue it in Australia?
I'm not sure.
Oh, okay.
And I don't mind leaving gel foam in if we need to. Yeah. Ryan, I'm not, oh, ligate. Yeah, so I find it very difficult to ligate that vessel. I think we're in pretty good shape here. All right, so I'll just do an intradermal suture pattern. There's not much else you can close in there. It's not like you can do several different layers. So I might be able to get a little sub-Q layer. Of course, I've hit the aorta again. So quiz question. I think we discussed it yesterday in-house, but for those of you watching, why is PDS on a cutting needle clear instead of purple? So why is PDS on a cutting needle clear? And I'll give you a few minutes to come up with an answer. So question is whether you can use electrocautery in this area in cats. And you can, but I just find that there's not a specific vessel that you can cauterize. And electrocautery does not work. Monopolar does not work in a pool of blood. And so basically I find that pressure and then maybe gel foam is the easiest way to go. Not the prettiest closure I've ever done.
309.
I can probably just do intradermal so we won't have to remove the sutures.
Okay, sure.
I use almost always intradermals rather than skins
For enucleation.
for everything. Some people say they like using skin sutures because it encourages people to come back for review, but with what people are spending at a specialty hospital, if you tell them to come back for a recheck, they probably will, even if it's just intradermals. Seem to have some extra skin here.
Do you want 40 or 30 is fine?
What do I have here?
30, that's the one that you used just now.
Yeah, that should be fine. Yeah, so the answer is that in humans, you're often using it for intradermal sutures, and so with light-skinned people, the purple would show through the skin. And so that's why they use undyed or clear. PDS. So just the way that I do my intradermals is I usually do kind of perpendicular to the skin margin rather than parallel. I know a lot of people go parallel with intradermals, but I just find that it makes for a little better closure. Like that. You happy to finish that up?
Yeah, sure.
Okay, come around this side. All right, so regarding monopolar electric cautery, I usually have mine somewhere between kind of 10 and 40 watts, and it just depends on the machine and how good your grounding is and that kind of thing. Just going back through to see if there are any questions that I haven't answered. I have a question. How are veterinarians paid in Singapore? And I don't know the answer to that. I think that everything seems to be kind of on par with what they're paid or what things cost in Australia. So I would imagine around 100K for a vet who's been out for a year or two. Is that about right? It's 100,000 for a vet who's been out for a year or two. Just a rough guess.
You can check on the Singapore Vet Association website.
You can check on the Singapore Vet Association website. Why do I prefer transpalpebral enucleation? I just think that it's easier to get a complete excision of all the mucosal membranes and conjunctiva and everything by doing it in that fashion. Hi from Malaysia. And just a bunch of comments about the audio not working. So if you haven't already done so, go ahead and wrap it up now. Please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone.